We talked about pain control. We talked about this. So that is a perfect segue into our next session, which is ERAS. I know we have Mary and Kurt already. Mary Brindle and Kurt Heiss are going to be presenting to us about ERAS. And Mary, are you going to be presenting those slides?
Yes, I am.
All right. So Mary Brindle and Kurt Heiss, we really appreciate you coming on. And this is a very evolving topic. I know it's exploded from me not using it at all to this becoming an everyday thing we talk about. So let's bring it up and see how many people are doing this.
All right, I'm going to share my screen. Can people see it?
Yep.
Okay, great. All right, Kurt and I have really been looking forward to this as being, for a while, almost lone pediatric ambassadors to ERAS in pediatric surgery, but this is changing certainly. Those of you who've been doing work in adult general surgical care will be relatively familiar with enhanced recovery after surgery. And I think this is kind of expanding and increasing in the pediatric surgical world. We figured the very best way of talking about enhanced recovery after surgery in pediatric general surgery is to really provide a bit of a case example. So I'm going to hand this over to Kurt to get us started.
Thanks for asking us to come and talk about this. Rather than asking you questions about what would you do, I'm going to ask you questions after I present the patient about why don't you do this. And so Mary's going to show you the MRE of the Crohn's patient that we'll present.
Who here in the faculty, how many of you are using ERAS protocols at your hospital now?
How about how many have tried? How many have tried?
So you tried and abandoned it, Mac?
You have to get a lot of people engaged, as they're going to tell us.
So Todd, this is a super good question because Mehul just published a paper recently about multidisciplinary engagement and how important it is. We'll come back to this in just a second.
Okay.
You all see this now?
No, it's perfect.
Good.
Okay, thanks.
So JG is a 16-year-old gal who has a tight ileocecal, a tight TI stricture, and she's lost some weight, hadn't been nutritionally managed very well. So she was sent to our clinic for questions about ileocecectomy. We gave her an explanation of the operation and then, and also about enhanced recovery. We put her on protein shakes and scheduled her for a few weeks later. Next. She was, on the day of her operation, she came to the hospital drinking high carbohydrate clear liquids. Unfortunately, I got the short straw that day and there was a liver transplant in my room. So instead of starting early in the afternoon, she started at 6 o'clock. Because ERAS was written on the board next to her name, the day surgery nurses gave her clear liquids during the afternoon. So, and they stopped it an hour before the operation. So she came into the operating room well hydrated. She was given a block and pre-op medications. Next slide. She had a single site procedure. A ERAS anesthesia protocol was invoked, and her total IV fluids for the case was less than 4 cc's per kilo per hour. When we finished her stapled resection, we had a closing protocol, changed the instruments and gloves. Post-operatively, we put her on multimodal analgesia with Tylenol, Toradol, and Neurontin. We allowed her to drink immediately, and she started to snack that night. The following morning, she was hep-locked, and then she was put on a regular diet. She ate. She had good pain control. PT showed up and started to walk her every 2 hours. We gave her Senna. She had an evacuation. And so at dinner time, the pre-op goals that we had set with her were all made. And so she went home that evening after a partial colectomy. And so Mac, and I would just ask you, what did you notice about this case?
Well, the first thing I noticed was the beautiful single site approach.
Okay. I'm sure that that's pretty common among my peers. So anything else? Or Matt, go ahead.
Just that, again, this worked beautifully. You met all your parameters. The nurses pre-op were flexible and kept the path going. This is the way it's supposed to work. The tap block was beneficial. I congratulate you.
Well, just to be clear, not everybody goes home in a day at our place. I had a 10-day colectomy a couple weeks ago that had complications afterwards. So we have the same challenge as you do, but it is more common, as you can tell, to have people meet their goals early. We had 2 FAP patients a month ago that went home in 2 days and after a proctectomy and colectomy. So why don't you put on the next slide, Mary? Let's just ask people. In your hospitals, would a patient like this be able to go home on post-op day 1? Any takers on that question? Jason, how about you? What do you think? Dan, any
When you
takers?
say your hospital, while we're waiting, I'm going to see who's turning off their mutes here. Dan's unmuted. I'll let him answer and then I'll go.
So at our institution, we've instituted a protocol across all surgical patients, which is discharge when physiologically ready, as opposed to waiting for for the surgeon to come by and say, yes, you're ready to go home. So my answer for my own personal patient would be absolutely. And I've done this, to do the patient when they're ready to go home, you send them home.
So Dan, I think that's a great answer. Let me follow up with that by saying, have you ever had patients who felt like they weren't ready to go home mentally when physiologically they had met all their discharge goals?
Of course. I think we probably all have. And if it's not the patient, it may be the parents. And I would suggest that as pediatric folk, we tend to be a little more lenient. At least I have been with saying, sure, you want to stay overnight, you can stay overnight. We'll send you home in the morning.
So Mary's going to show an infographic a little bit later during her section. You go on, Mary, the next slide. But about 10 years ago, the Adult Enhanced Recovery Group did a really nice study where it talked about the parts of the ERAS protocol that were most influential. And they identified mobilization and oral intake as being the most important after talking with the families about what these discharge goals would be, because they found that about half their cases were ready to go home physiologically 1 to 2 days before they actually would agree to go home because they were afraid. And so having this pre-op optimization period and heavy counseling is really important. In the NISQUIT meeting that's going to be later in the month, we have one of the nurses is going to talk about how she calls them several times during the period before their operation and goes over these things and reassures them that they will be, when they meet these goals, they'll be safe to go home. Were there any other things like Mac, Dan, any others about getting the patient ready or optimizing the patient? How would this be done at your institution?
As I suggested earlier, my institution is not really latched on yet. It requires getting a lot of people in line, and just had some resistance and need to keep working on it.
Okay. Would any of you guys give oral supplements beforehand to change the trajectory of their visceral proteins? Mark, how about you? You do bariatric cases.
Trying to set me up there, Kurt. So in my previous institution, for sure my patient would go home. We don't do the protein supplements ahead of time. As you and I hadn't really talked about that before, but I think that's just about normal nutrition, getting your patient ready for surgery. You don't mention the preoperative carbohydrate drink, which in my bariatric patients, again, all these, the ERAS and implementing ERAS is really a multidisciplinary endeavor. So you really need to get everyone's buy-in. One of the hardest things in the obese patients is getting the anesthesiologist buy-in to giving the preoperative carbohydrate load. We'd let them, we'd let them drink up to 4 hours before, but they wouldn't let us get too close. Although I think that's subject to change as well. But in our bariatric population, after sleeve gastrectomy, we're able to get over half of our patients out on the first post-operative day. But again, I think the preoperative education is key because, you know, like a lot of these patients and a lot of your patients, when you do this, are going to be like, well, wait a second, you know, I'm not ready up here, not physiologically. And having those conversations ahead of time is very important.
So one of the things that Mark just brought up, which was kind of important at our institution, is after 8 years of doing enhanced recovery and not having aspiration events, we, in our quality council, went to the anesthesia teams on all of our campuses and asked them to change our NPO times from this 20-year-old arrangement, which said 2 hours was okay, to making it 1 hour NPO time. So on March 1st, for all of the 43,000 procedures that are done in our institution on an annual basis, the NPO time for clear liquids became 1 hour. And that was, I think, very important because both Mark and I have worked on that for quite a while. Mary, why don't you go to the next slide? So this patient did not get mechanical bowel prep, just got oral antibiotics on the day beforehand. Any takers on that? Obviously, we all know that there are meta-analyses that suggest that bowel preps can be helpful, also suggest that oral antibiotics can be helpful.
I think we've been around and around and around on this, and there are data.
Pass on that one.
There's a lot of data and a lot of opinions.
Okay, fair enough. Next slide. Okay, so one of the things that I thought you might have focused on but didn't was the pain team involvement. So early in our practice, we had a marginally functioning pain team, and we invited them in to the ERAS club and got them involved. We gave them a lot of opportunities to regional blocks. And for a year, we did epidurals. It was a disaster. The epidurals slowed the patients down dramatically. So we just went to QL blocks, rectus sheath blocks, or TAP blocks. Once we started doing that, it made it much easier for the patients to ambulate. The question here about the multimodal analgesia, many of the protocols that you'll read about in colorectal surgery have people getting PCAs. By giving the pre-meds on the morning of the operation or the day before the operation and giving them a block, and then scheduling the medications post-op, we're able to do a pretty good job at meeting their pain control. Mary's going to show you in a minute the decrease in narcotic utilization in our institution once this started, and that becomes socially a big deal as well. When we can do colectomies or craniofacial operations with no narcotics, it becomes a really big deal for the family. Mary? So I wanted to wrap this up. Todd, this is going to blow your mind. I'm going to finish before my 15 minutes is up.
Oh my gosh.
I know. Someone protect his airway, please. The important points I wanted to make as we tap the brakes and get ready to shift to Mary's presentation is we spend a fair amount of time on patient engagement. Now, I do a good job of that in my clinical visit, but we have NPs who reinforce this. So as Todd mentioned before, repetition is a learning principle for all of us. Right at the beginning, I gave grand rounds to the anesthesia department. I did it twice, and the chair was there for these presentations. She was very excited about this, and so I got a lot of support right at the beginning. We got one of our superstar NPs to be the queen of enhanced recovery, and so we got nursing on board, and they became quite big advocates for it. We changed the NPO time, we did schedule medications, and reinforced, as Dan said, the importance of giving people an understanding of what a safe discharge was so that they would not dig their feet in and decide they wanted to stay for a long time. So anyway, I'll pause here at this point and ask Mary to take over.
I thought that was going to be a great mnemonic, but I tried saying it was parafamda, so it doesn't.
I think it looks like perf is what it looks like.
Well, I think it's probably a good time to just sort of quickly go over exactly what enhanced recovery after surgery is. And I think many of us feel that, that we do enhanced recovery after surgery in some form or another. But if we actually look at it as the overall big picture, it's a multidisciplinary, multimodal, evidence-based way of delivering care to patients. So the goals are to optimize patient physiology throughout the entire perioperative pathway. The strategies are to decrease operative trauma, inflammatory response, and stress. And the typical tactics that we use within that are things like optimizing fluid and analgesia, mobilizing early, feeding early. And these all get bundled up so they act synergistically. So I would say that one of the important things about enhanced recovery after surgery is that the whole of it is greater than the sum of their parts. And the outcomes are that they heal faster, they go home earlier, they have fewer complications. So that's, the overall picture of what that looks like. And the adult world has a huge amount that's published on the benefits of enhanced recovery after surgery. And certainly there are a lot of surgical benefits in terms of complications, but also there's a decrease in non-surgical complications. So the parentage of enhanced recovery after surgery often sits in our fast track surgery programs, where there has been shown to be reduced length of stay after surgery. And a lot of the concern has been that this comes at a cost of increased readmission. I think it's one of the benefits of enhanced recovery after surgery is that this kind of holistic process, this involvement, this focus not necessarily on just getting patients out, but on that full spectrum of care should, when done well, decrease the readmission rates. So the question was asked earlier, do you use enhanced recovery after surgery? And I guess I would open that up to say, if you do use it, do your patients know that they're an enhanced recovery after surgery patient? Do the nurses know that they're looking after an ERAS patient? And do the anesthesiologists, are they aware when they're looking after them? And do they have a protocol for those patients as well? And so I'd be interested in getting any sort of opinions from the group on that.
Mary, can you ask the question one more time?
Yeah, so the question that I would say is, if you are using enhanced recovery after surgery, are your patients aware of that, or their parents? Are the nurses aware of that? And are the anesthesiologists, are they also following enhanced recovery after surgery protocols?
So that actually leads to the point I wanted to make earlier. All the other things we've talked about up until ERAS are things that the surgeon can pretty much decide to change their practice. This one, not so much. And this is such a massive team approach that that's why people struggle with getting it started. It's the ultimate in multidisciplinary change, and it's a big change at that. So it has to come from the leadership above, where the head of surgery, the head of anesthesia, the head of nursing, the head of patient relations, they all meet together to make sure everyone's on the same page. I like to give a carbohydrate drink, because I learned from Kurt a few years ago at the update course. But I'm too terrified to do it, because if it happens to be a single anesthesiologist that's on that day and they're not up to speed, then I just totally ruined everyone's day. So it won't happen without a total multidisciplinary approach.
Todd, I was going to make the comment to Mary that there's no way that I can use ERAS without all those other people being on doing ERAS. So there's no way a surgeon can do it.
Yeah, but if you have somebody persistent like Kurt, you can get it done, and that's what it requires. I mean, Kurt did a fantastic job in Atlanta, where he got anesthesia involved, and Kurt actually sort of did it subvertly on his own for a few years, and was collecting his own return to the system and repeat, readmission rates, so that he could then kind of come up and show us, look, I've been doing this for 5 years. It's all fine and it all works, which was really an interesting way to do it, to just hit us with data, because I do think people respond to data. Yeah, Salim's saying Kurt is subversive. Yeah, he can.
Mark, I'll give you an example. So I'm going to be the surgeon. I want to push the envelope. I want to try it. I know it's a little risky because whoever's on that day may say no. I need to know there's a number to call, like you, that would, I would feel safe that I know if I get there the morning of and the anesthesiologist says no, I can call the Mark hotline and I know I don't have to worry about it because you would overrule it. I would have to know that that leadership came from above.
Well, and you can't do it without involving everybody. So it's sitting down with the nursing manager on the floor. It's sitting, and we even got Epic involved because on the OR board, there's a little icon in Atlanta for ERAS so that everybody knows the patient's on ERAS. So once it becomes institutionalized, then you can do that. And so if you have the rogue anesthesiologist, it's like, wait a second, we're not doing this. It's like, wait a second, your chief of anesthesiology said that this is okay. This has been communicated to you. We all know about this. If you're not willing to do it, we'll find someone who is.
And I think what everyone's saying, I think, is exactly what Kurt and I would, we're hoping to hear, is that yes, it does require you to be a champion, but you absolutely cannot do this alone. No matter how much passion you have for enhanced recovery after surgery, it has to be a team sport.
So we collected data for 6 months on the 1 hour NPO time. And then, Todd, just like you, the people at our institution were anxious that if a patient misbehaved or something like that, that it would slow the cases down and they'd be behind. But we found the data was the opposite, is that if you made a point of, in my office, I make the parents raise their right hand and say, I promise I will give my kid a Gatorade while I'm driving to the hospital, because sometimes they think it's such suggestion, okay? And when they agree to do that, and we make sure that it's not coffee with creamer they're giving the kid or an Ensure, then we didn't have any delays during that time. And so that really captured people's attention and got them on board.
And I will say that data is really valuable in getting this going. I think, Mark, it was you who said that. And I think even things like the surgeon will remember that one single case where they had a delay because their patient was given fluids within the hour. It should be rare if you've got a good system. But if you actually have good data to show them how it's actually working, a lot of the times you can get people on board. And I also feel that it's really important, and this is why I have this slide up, to show people the overall impact. So not even just to rely on the studies that are out there, but to actually show the difference. Because as you implement enhanced recovery after surgery, and this is a study that was done by Kurt and Mahol and his team in Emory, that over the course of years with additional ERAS elements that were adopted, additional work for implementation, that there's decreased intraoperative fluids that are given, decreased intraoperative and post-operative narcotics, decreased time to getting on a full diet. And along with that, these patients get better faster, they're happier, they go home quickly. And I think that data really does speak for itself. I'm going to switch gears a little bit, get to a 30,000 foot view. And this case, I'm going to actually change the patient to actually being your center itself. So this really could be any neonatal surgical center, but let's say that it's yours. And you are looking at your patients who undergo abdominal surgery. You think that they're actually doing pretty well, but you decide to look into it. You've got NSQIP going, so you pull up your results and you get a little bit disappointed to see, you first look at your SSI rates and you realize that you are a significant outlier at your center, that your center has very high SSI rates. You look into it and then you realize that your patients are staying long in hospital. You go to the NICU and you realize that they're being ventilated longer, they're not feeding quickly, you're more and more discouraged. You talk with the nurses, they say there's just poor communication between teams, and the practices that you thought were being followed are really not being carried through the way you thought they were. And I'm going to pause here and say that this probably occurs at way more centers than we're aware of. We often feel like we're doing the right thing by our patients and that our practices are good, but there's a lot between us knowing that we should be doing something and that patient actually receiving that treatment. So I guess I'd pause here by saying, what is the problem with a unit like this, and how do you fix it? Do you develop a pathway for those neonates that are undergoing GI surgery? Do you choose a few practices and adopt them across all surgical neonates to improve care? Do you try to do some type of combination of the two? And I'd be interested to see, I'm sure other folks have identified problems in their neonatal surgical units, and what sort of approaches have you taken?
So Mary, there's Dr. Durham could talk a little bit about this. We began to use enhanced recovery in our newborns and found that the kids with motility problems, like in perforated anus, all the other enhanced recovery principles worked well, but feeding them immediately was not a great idea. There is a paper in publication in JPS right now on duodenal atresia repairs and enhanced recovery that shows that they have an excellent return rate, a recovery rate, and without a increased return rate. So there are neonatal things that can be done to help this, and that's the softball I'm throwing to you, so you can hit it out of the park with your neonatal.
Yeah. Well, I figured this would be a good time to share our neonatal intestinal surgery enhanced recovery after surgery protocol. And this has just been published a little bit earlier this year. It's one that was built from scratch. There's a number of elements that would look similar to adult ERAS protocols, but these were really generated individually and evidence-based. You can kind of see, especially if you start using these, how a lot of these various elements end up working together. They work synergistically, and you also realize once you start using these that it is exceptionally hard to limit this type of practice to the subset of patients for which you initially intended to use it. So if you're targeting infants who are undergoing intestinal resection surgery and you start developing care pathways that are opioid sparing, for example, the other patients who are undergoing surgery will often end up benefiting from this type of thing as well. And once you start having teams that get invested in this, they naturally want to start adopting other elements of enhanced recovery after surgery care. And I actually feel like opioid sparing analgesia is a really good one to think about, because I actually feel this is one of these areas where many of us and many of our centers could probably still do with a little bit of improvement. So I'd ask, this is a very simple question. Do you usually treat neonates with opioids after they undergo GI surgery? This is in the post-operative period. So I'd send that out. We could, we could, for example, this might be a good time to do a show of hands for those of you who are on Zoom with us. And so this is just typically. So do you typically treat neonates with opioids after intestinal surgery? Hands up those who do. All right. And hands up those who do not typically use opioids.
So Mary, I think it's important to ask the question, if the newborn is being treated by the surgery service and getting a inguinal repair or something as an outpatient, that's a different question than if they're in the NICU with some other complex problem.
And that's why I said GI surgery for this rather than like hernia surgery, which I recognize is probably a bit of a different kettle of fish. And I suspect many of us have migrated towards less opioids. I've got to say that in where I work, it has been traditional thinking that it is impossible to treat neonates after GI surgery without opioids, that is actually not even something worth considering. And I think it is worth stepping back and looking at, first off, if it is possible and are there benefits to it. And this is an interesting study done by Jeff Gander's group. They presented it at APSA in 2019. And Jeff basically presented the work done by their group in Virginia, where they looked at infants undergoing intestinal surgery. And they used things like regular non-opioid analgesic, IV acetaminophen, opioid limiting strategies, non-medical things. And they saw a dramatic decrease in the use of opioids. And I think and this kind of brings us back to looking at the holistic nature of enhanced recovery after surgery, that pain control, of course, addressing pain control is basically just being a humanitarian. You do not want infants to suffer pain. But if you are able to avoid opioids, the downstream benefits in a neonate are quite considerable in terms of decreased duration of ventilation, earlier time to feed, shorter length of stay in the neonatal unit. And it is actually possible. But if you look at this from a relatively simplistic point of view and say, well, all you need to do is just use IV acetaminophen and what have you, the recipe itself is insufficient. And this was brought up by, I think, many of the people who are on the panel at the beginning of this discussion, that it is absolutely crucial that this be a team-based approach. So implementation involves getting people on board. It's a team-based strategy. You can't roll this out in a day and expect it to work, that there has to be knowledge from those people who are involved, investment in those people, getting the parents involved is absolutely crucial. And you have to continually be that champion. And there was some comment on, if you find that, that you're, say, dealing with an anesthesiologist and say you're more junior staff or what have you, that you have that person that you can call who's going to back you up so that your patients get the very best available care. And this is, I think, one of the things that makes enhanced recovery after surgery extremely challenging, but extremely effective, in that implementation has from the very beginning been a core aspect of this. And we have a couple minutes that I wanted to give to our closer, Dr. Heiss, again, to run through just a few little considerations.
Okay, so I think one of the really important things we talked about is the multidisciplinary nature. So Mehul has an article in publication right now that talks about 18 centers that are involved in his multidisciplinary, or in his enhanced recovery protocol. And all of the centers, many of them say we're already doing enhanced recovery, but they actually measure the number of items in the protocol, and it turns out that it's only about 5 usually. And they have really focused a lot on the surgeon's component rather than on the multidisciplinary nature. So once you put the next slide up, just to see if Todd's still awake. Okay, so this is Dr. Wolkin's favorite movie. It's kind of a cult flick. It's called The Matrix. And you may think Morpheus is inviting you to join the resistance. He's really asking you if you are going to do enhanced recovery or go back to your old-fashioned way of doing things. So why don't you go to the next slide? So it just so happens that The Matrix came out about the same time as the original ERAS paper came out. And so let's talk a little bit about implementation strategies that you might use to make this work. Next slide. Why don't you skip to the next one? So one of them is to do this as a protocol, which we did for the IBD patients. There's as a quality leader in my hospital, I went to all of the surgical divisions and about 3 years ago, asked all of them to pick one bucket of CPT codes. And Dan, I thought this was interesting because you've embraced part of this, and the way you said that everyone was going home when they met their discharge goals rather than waiting for the attending to come around. And so I asked the plastics guys to do this, and they picked craniofacial surgery, surprisingly. And they did do palates 2 or 3 a week. And so they made a protocol for palatoplasties where they doubled the oral intake of their palate repairs and dropped their length of stay by about 70%, and did it by reducing their opioid consumption in a group of patients that were less than 2 years of age. Next slide. The alternate strategy would be to break it down into parts and focus on the NPO time, which we did, or on the opioid use, which we did, or get the pain team to be working more effectively. Our current focus right now is trying to get all of our patients out of bed and ambulating every 2 hours, because the data in adult series showed that oral intake and ambulation is the dominant factor in getting patients to go home.
So the problem is I have a lot to say, but I'm also trying to get us on track. And I know every time I talk, it gets extended. There was a question about what was the answer to the pre-op bowel prep. Ileana wants to know if there was an answer to that, Kurt or Mary.
So I don't, I give patients oral antibiotics, and if they're a motility patient, I would bowel prep them. But if they're not motility patients, I might give them Senna the day before and put them on clear liquids. But otherwise, the oral antibiotics seem to be super important at decreasing bacterial loads. And it's really about surgical site infection, and it's been super low in the ERAS protocol.
So there was a request to have a full day on ERAS. I think we want a full day on everything. The problem is I think there's been webinar overloads. So we have to figure out how to do it efficiently and get the right amount of content out there. But it's almost like small breakout groups. If there's a lot of people interested in ERAS or gas or any of these things, let me know and we'll just have an event, and there's no skin off our back to do that.